Hi, we're group 6. My name is Stephanie. We're going to be presenting on pneumonia. Our case study consists of patient JD, who is a 70-year-old male who was brought into the hospital by his daughter because of a rapid rising fever over 100 degrees, extreme fatigue, was experiencing shortness of breath, chest pain, and continuous coughing up green sputum. He has a history of smoking, alcohol abuse, COPD, and hyperglycemia. Upon admission, JD's vitals consisted of blood pressure 150/94, respirations 32, heart rate 100, and oxygen level saturation 89%. Now we're going to go ahead with Dana.
All right, I'll be talking about the patient's chief complaint, which is fever with chills, malaise, loss of appetite, and myalgia. There are other manifestations of pneumonia that include chills, a cough that produces rusty or purulent sputum, crackles and wheezes, dyspnea, and chest pain. And I'll pass it on to Judy.
Nursing diagnosis is ineffective gas exchange related to accumulation of fluid in the lungs, as evidenced by rales and mild wheezing upon auscultation, O2 saturation of 89, and shortness of breath with activity. The goal for this patient is to improve patient oxygen saturation greater than 94 without supplemental oxygen before discharge, and the patient verbalizes easy breathing. 3 interventions is administer antibiotics per physician order, monitor lung sounds every 4 hours or as needed, and to ensure the patient's head is elevated semi-Fowlers every 2 hours. And I'll pass it on to Cheyenne.
Okay, so the pathophysiology of pneumonia is that it is an infection in the lungs that causes inflammation to the alveoli, and it's caused by bacteria, viruses, fungi, and even parasites that can enter the body. Usually mucus that lines the respiratory tract catches the microbes and causes you to cough them out. And cilia that lines the respiratory tract pushes the mucus and microbes out of the body through coughing. But sometimes the microbes can pass the cilia and enter the alveolar space. In the alveolar space, white blood cells typically attack these microbes because they're foreign to the body. But if the patient has a weakened immune system, the white blood cells are not as active, or they're not in such high numbers, and then these microbes can start multiplying. Once they start multiplying, they the alveoli also produce exudate, and they get inflamed, and this causes fluid to accumulate in the alveolar space, and it causes deficient gas exchange, and it can also cause inadequate ventilation of the lungs. The deficient gas exchange can cause the pulmonary circuit blood to become poorly oxygenated, and this blood can mix with regular oxygenated blood, and it can cause atrial hypoxemia. It can also cause pulmonary effusion, and as well as shock and respiratory distress, but shock and respiratory distress are more common with patients who do not receive specific treatment and patients who receive inadequate or delayed treatment. Pneumonia is typically diagnosed by getting a patient history, specifically looking for any respiratory tract infections recently, or seeing if the patient is prone to respiratory tract infections. A physical exam will show any abnormal breath sounds such as wheezing and crackles. A chest x-ray will determine if there are any abscesses or infiltration in the patient's lungs. A sputum test to determine what kind of microbe is causing the infection, and usually sputum is purulent. A CBC can also be done, looking for any leukocytes or increased number in white blood cells. And pulse oximetry is done to determine if there's proper oxygenation and circulation. I am going to now pass it on to Stephanie.
So some of the expected assessment findings for a patient with pneumonia, you would expect to hear abnormal lung sounds such as crackles or bubbling noises and wheezing, and also use of accessory muscles for breathing and coughing. And you would expect to see green, yellow, or bloody mucus if sputum is produced. You would also expect changes in temperature and pulse, the severity of cough and tachypnea. And a chest x-ray would show multiple abscesses and bacterial infiltration. ABGs would show abnormalities. A gram stain or culture from a sputum collection would show the presence of bacterial or viral microorganisms. And the patient will also present with respiratory distress, chest pain, fatigue, fever, chills. And we would expect to see dehydration, altered mental status, and unusual behavior in older adults. So now I'm going to go ahead and pass it on to Nancy with medications.
Okay, so moving on with medications, treatment for pneumonia may include antibiotics or viral or fungal medications. It may take several weeks for the patient to recover from pneumonia, and the patient's provider will select the right antibiotic for them based on numerous factors such as age, health history, which may influence their ability to fight off infections, the exact infection the patient has with a blood culture to identify the pathogen, previous experience with antibiotics, and antibiotic sensitivity of the bacteria. So a few different antibiotics that these patients may be given include amoxicillin plus a macrolide, like azithromycin, or tetracycline, like doxycycline, in healthy adults under the ages of 65. If they're an adult with other illnesses or they're smokers, then they may be prescribed Augmentin, which is amoxicillin, and clavulanic acid. Patients who can't take penicillin may be given Rocephin or ceftriaxone, and infants, preschoolers, and school-aged children may be given amoxicillin. Some other medications that could be prescribed include macrolides, antipyretics, antitussives. Macrolides are recommended for patients with drug-resistant Streptococcus pneumoniae. Antipyretics are used to treat fever and headache. Antitussives are used for treatment of the cough. And then lifestyle and home remedies include to get plenty of rest, to stay hydrated, and to take your medication as prescribed. Because if you stop taking the antibiotics or medications too soon, your lungs may continue to harbor that bacteria. And then oxygen administration may be used as medical treatment to improve the airway and respiratory function as well. Moving over to patient education, you can educate the patient to improve respiratory function by practicing breathing exercises to promote secretion clearance and volume expansion. You could also teach them to maintain adequate fluid intake or hydration to help increase ciliary action to remove the secretions and reduce the viscosity of the secretions. The thinner the secretions, the easier it is to expel and cough out. And you can also educate your patient on overall wellness and to develop good health habits to fight pneumonia, such as washing your hands, having a healthy diet, getting adequate rest, regular exercise, and to avoid smoking. Proper management of signs and symptoms is also important, and to know for the patient to know when it's necessary to follow up an appointment with their provider. I'm going to go ahead and pass it over to Judy for trach care.
For trach care, it's a sterile technique. This is to avoid contamination and infection. It's important for patient education and teach them how to suction, clean, and replace the trach inner tube and the opening of the neck, which is the stoma. For suctioning, it's needed 3 to 4 times a day or as needed. It's important to assess the patient's pain and give medication if needed. If the patient is conscious, place them in semi-Fowler's position. And it's important to perform hand hygiene and prepare a sterile field. Never suction for more than 10 to 15 seconds at a time. And always suction using a dominant hand, which is your sterile hand. And use your non-dominant, which is the clean hand, to control the suction and give 3 to 6 breaths using manual resuscitation bag. Allow at least 30 seconds to 1 minute interval for each suction to allow ventilation and reoxygenation. For stoma care, it's important to clean and dry the stoma 2 times a day or as needed, and to assess the skin around the stoma and apply cream if needed. You should also clean the inner cannula and replace 2 times a day or as needed. Now I'll pass it on to Dana.
And I will be talking about the oxygen delivery devices. Let me just share my screen. Can you guys see it? Okay. All right, so for the oxygen delivery devices, oxygen can be administered by many different systems, including the nasal cannula, the simple face mask, the partial rebreather mask, non-rebreather mask, and the Venturi mask. So the nasal cannula is right here. And that's the most commonly used oxygen delivery device. It delivers at a low flow for 1 to 6 liters per minute. The cannula is connected to the oxygen source with a flow meter and in many times a humidifier. And this one can be administered using the nasal cannula by either low flow or a high flow system. And then we have the simple face mask here and here. This delivers at 5 to 8 liters per minute at low flow. And this mask vents on its sides that allow the room air to leak in at many places, and it dilutes the source of oxygen. And then the vents also allow exhaled carbon dioxide to escape. And this mask is used when an increased delivery of oxygen is needed for short periods of time. And because of the risk of retaining carbon dioxide, you should never apply a simple face mask with a delivery flow rate less than 5 liters per minute. And then we have the partial rebreather mask. This one is also low flow and it delivers from 8 to 11 liters per minute. It's equipped with a reservoir bag right here for the collection of the first part of the patient's exhaled air. And then the remaining exhaled air, it exits through the vents on the side. And an advantage of this mask is that the patient can inhale air through the openings in the mask if the oxygen supply is interrupted for any reason. And for this specific mask, you should be monitoring the reservoir bag because it should deflate slightly with inspiration, but if it deflates completely, the flow rate should be increased only until a slight deflation is noted. And then we have a non-rebreather mask right here. This is also a low flow, 10 to 15 liters per minute. This specific one delivers the highest concentration of oxygen via a mask to a spontaneously breathing patient. And the reservoir bag is filled with oxygen that enters the mask on inspiration, and exhaled air escapes the side vents. And then a malfunction in the bag could cause carbon dioxide buildup and lead to the patient being suffocated. And then we have the Venturi mask right over here. This is a high flow system of 4 to 6 liters per minute. And this allows the mask to deliver the most precise concentration of oxygen. And this mask has a large tube with an oxygen inlet. And as the tube narrows, the pressure drops, which causes the air to be pulled through the side ports. And the side ports are adjusted according to the specific prescription for the oxygen. And you have to make sure that the ports are always open. And that's the end of our presentation.